All rise.
Please be seated. Notice anything? I need to thank Paul and Susan. The PFM was giving us problems, and mysteriously they all disappeared this morning. I don't understand. But let's see how it works, okay? We're going to continue on with the testimony. Oh, one other thing. I've had a scratchy throat all week. I tested this morning, I'm negative. So if you see me up here eating cough drops, it's a little scratchier this morning. So, but I just want to let you know I'm safe, I think. With the weather change, another cold. Okay, we ready to proceed, Ms. Sawyer?
We are, Your Honor.
Call your next witness.
State will call Troy Rudman to the stand.
Y'all have a good evening? I'm waiting for this weather to come. Thank God we're off Friday, because that's supposed to start hitting Friday.
Yeah.
Okay, sir, I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, Your Honor.
Okay, once again, make yourself comfortable. You have an aerial mic there in front of us. If you wish to lower your mask, you may. Okay? I need you to state your name and then spell your name so this young lady can get used to your diction. Okay? Go ahead.
My name's Troy Rudman. Spelling is T-R-O-Y. Last name R-U-D-M-A-N.
You guys hear him? You want some volume? I know you got a little bit more in you. Okay?
It's early.
Give us a little more volume. Ms. Sawyer.
Thank you, Your Honor. Mr. Rudman, let's start with your background. Where did you go to college?
Yes.
And where did you go to college?
Mount Carmel College of Nursing.
Okay, and what degree did you get?
Nursing degree.
When did you receive that, Mr. Rudman?
In 2014.
All right, I'm going to ask you to speak up a little bit, okay, because I'm having a little bit of trouble hearing.
In 2014.
Okay. After that, what did you do after you received your nursing degree?
I took the boards for nursing and then got my license in July of 2014.
Did you work as a nurse after that?
Yes, at Mount Carmel West.
Okay. When did you become employed at Mount Carmel West, sir?
In August of 2014
And how long did you work at Mount Carmel West?
until July of 2019.
And what happened there, Mr. Rudman?
I was terminated.
At some point, because of your employment at Mount Carmel West and what happened, did you have to go before the nursing board?
Yes.
And tell us what happened with that.
It was a state,
I would just note an ongoing objection. Thank you.
Okay, overruled.
Go ahead, sir.
it was a state suspension, so I still have my license.
Okay. And are you currently employed
I am
in a medical field or a non-medical field?
non-medical field.
All right. Let's talk a little bit about when you first started working at Mount Carmel West. What were you doing at that time, sir?
I was hired on as a staff ICU nurse in the neurological ICU.
And how long did you work in that position?
About 6 months, and then our departments were merged into the entire ICU, so medical, surgical, cardiac, and neurological.
Okay. And what did you do at that point when they merged?
Staff ICU nurse.
How long did you hold that position?
Until January 1st of 2017, when I became a rapid response nurse.
Tell us what a rapid
hold on.
response nurse is.
Bring the volume up a little bit there.
In 2017, I became a rapid response nurse. That's a nurse that is tasked with going to every floor and trying to prevent ICU rebounds, so people that were transferred out of the ICU so that they didn't come back to the ICU, and also responded to code situations, emergent situations, and facilitated transfers from the the normal floors to the ICU.
Now, when you responded to emergency situations, what was your role in regards to that as a rapid response nurse?
So my role, I would show up, anyone in the hospital had my direct line, they could call me. I would show up, analyze the situation, speak with the nurse assigned to the patient, and then basically do whatever was needed for that patient in that given time.
So you were all hands on deck?
Yes.
Okay. How long did you hold that position, Mr. Rudman?
Until December of 2018.
And what happened at that point?
I was put on administrative leave
And how long were you on administrative leave?
until July of the following year, 2019.
Which was when you were terminated.
Correct.
As a neurological ICU nurse, what were your job duties for that?
In the neurological ICU, we would deal with traumatic brain injuries, strokes, primarily patients that had any brain injuries or any acute traumas to the head or brain.
And you said you would deal with them. What were your specific jobs in regards to those patients?
As a neurological nurse,
Correct.
to monitor, to assess, to carry out orders given to me by a physician.
When you switched to just a straight ICU nurse, what were your job duties at that point?
The same role.
And at this point, what type of patients are you caring for?
Any patient, really. Any surgical, cardiac, neurological, general medical. It was an entire ICU that was a mixed ICU.
I would say for the years you worked at Mount Carmel West ICU, you became very familiar with the ICU unit. Would that be accurate?
Yes.
When you first started, what type of orientation or training did you receive coming straight from nursing school in your board and going straight into working?
So we were paired with an orientee, which was a tenured nurse on the unit.
Okay.
We followed them around and helped them in their day-to-day, so learned on the job for about 10 weeks, and then we took our own patients after that.
Was there any type of ongoing training at that point?
There were some health stream modules, which was the hospital's education department, and much past that, it was mostly on-the-job training.
And once you received your nursing license up until today's date, is it still in a valid nursing license?
Yes.
And you maintained all the continuing education courses you needed to do so in order to maintain that?
Yes.
Mr. Rudman, I'm going to direct your attention, and this has been marked as 15BB. Can you identify that for us?
That's Mount Carmel West.
Okay. And I'm going to show you what's been identified and marked for identification as State's Exhibit 15B. Do you recognize that?
I believe that's the family room we use for loved ones going through difficult situations, and it would be a place where the physicians could speak to them directly in a quiet, controlled environment.
And that's at Mount Carmel West?
Yes.
In the ICU area?
Yes.
Okay. And what's been marked for identification as State's Exhibit 15C, can you identify that for us?
I'm not sure.
Okay.
This might be the same room, but I'm not sure.
If I can show you. All right, certainly looks like it.
Yeah.
Would you agree? And 15D appears to be another angle of that same room.
Yes.
And then what I've marked for identification as 15E, do you recognize that?
Yes, there's the Pixis machine in the back of the ICU.
All right, and that would be this area?
Correct.
15F?
The same.
Pixis machine again?
Correct.
15G?
Another view of the same Pixis machine.
15H?
Another view of the Pixis machine.
15I?
Another view of the Pixis machine.
And 15J?
The Pixis machine.
All right, now tell us a little bit, what is the Pixis machine? What type of, does that mean to you?
The Pixis machine was used to get medications for our patients. It held any medication that we needed or used in the ICU. For the most part, we would scan our badge, use our fingerprint, and have a login, dedicated login for access to the Pixis machine.
All right, so if you withdrew medication from that, did it create an electronic record?
To my knowledge, yes.
And it would show, because it's a login and your fingerprint, thumbprints used, it would show it was you?
Correct.
Can you identify 15K for us?
It's a room in the ICU.
And 15L?
The same room in the ICU, room 9.
15M?
Another view of the ICU room.
15N?
The ICU room with the patient's bed.
15O?
This is the back of the patient's room that shows the monitor.
Okay, and explain to us what the monitor and this whole area is for us.
The monitor was used to continuously monitor the patient, whether that be blood pressure, heart rate, oxygenation. There was also access to oxygen and suction on that same pillar next to the monitor itself.
And was that common for all of the ICU rooms at Mount Carmel West?
Yes.
15P?
That is the back of the room, which showed the sink and toilet that we could access.
15Q?
Sitting area in the patient room.
15R?
Another seating area in the ICU room.
15S?
The bed and the computer monitor that we would use.
How is this monitor different from the other one we talked about?
The computer monitor we would use to chart, to scan in medications. Really any aspect of our assessment was charted and utilized through that computer.
Now, you just said you scan in medication, so once you withdraw the medication from the Pixis machine, what do you do from there?
So from the Pixis machine, enter the room, obviously, log into the computer. We would scan the patient's ID band.
Okay?
We would also ensure that the order was under the correct patient at the correct time, and then we would scan in the medication itself under the certain time that it was due in the medical administration record.
So I'm assuming there's a bar on the medication vial itself?
Yes,
And is that the scanner area I'm looking at there?
that's correct.
Okay. And I probably should have switched the picture to 15T because that shows it's a close-up. Same monitor?
Yes,
And close-up of what we just talked about.
yes,
And 15U, again, same thing?
yes.
15B, what is this?
That is the front nurse's station, and it has the front Pyxis machine to the right.
Okay. Explain to us why this is the front. Is there a back area also?
Yes, the first pictures were the back area of the ICU. It was a large unit, so
Okay.
there was multiple Pyxis machines throughout the different units because of the number of beds.
Do you know how many beds there were in the ICU at Mount Carmel?
I don't remember the exact number.
Okay. And the back area, you said we saw first, so this is the front area.
Correct.
Do you remember how many Pyxis machines were at the Mount Carmel ICU?
The main ICU, there were two.
Okay.
There was also a Pyxis machine in the CV ICU, or the cardiovascular ICU,
Okay.
which was next door. And then we also had a step-down ICU that had its own Pyxis machine.
Now, we've heard some talk that the ICU may have been on multiple floors.
Correct.
How many floors, sir?
When the neurological ICU was in existence, there was technically 2 floors, but they were split by multiple units.
Okay.
So there were, or 3 floors, I should say, with the step-down ICU. There were, the main floor held the medical ICU and the cardiovascular ICU.
Okay.
And then there was a separate floor for the step-down ICU, and the neurological ICU was across the hospital on a separate floor.
All right, now that's the first time we've ever heard anything about a step-down ICU. Can you explain what that is to us?
The step-down ICU was brought into being because we needed some overflow at times, and then also when there was a lack of beds in the hospital, and some patients were potentially too sick to be in a normal hospital floor, but not sick enough to warrant an ICU bed, we would have a step-down ICU that would help with that overflow, and that would be staffed by ICU nurses.
Okay. All right, 15X, what is that?
That is the front Pyxis machine.
Okay. 15Y.
Another view of the front Pyxis machine.
All right, now if you are withdrawing medication from the Pyxis machine, where do you go to enter your thumbprint and your ID code?
At the main monitor on the left, to the right, there's a small circle that would be used for our fingerprint.
Okay.
Hold on, you have a pointer.
Yeah, I was going to say, I think there's a laser pointer up there.
Would that help you?
Can you see if you can
Yeah.
point that out to us?
So this would be the fingerprint sensor on the Pyxis machine.
Okay.
This would be the main screen that we would use to input the information, and then the keyboard right
Okay.
here.
And where do you obtain the medication from then?
Depending on what medication, there was a fridge that held refrigerated items.
Okay.
There were drawers in this unit. There were also drawers in this unit, another fridge that had overflow, and then they called it a refrigerated section, but this was just a shelving system that held other medications as well.
So if you enter your thumbprint and your ID, does the drawer pop open, or do you have to actually physically open it?
So you would have to choose the patient
Okay.
that you were accessing medications for.
Okay.
Dependent on the medications that you chose, the various drawers would open after you hit accept that you were withdrawing those medications.
Okay. All right, so going on with the remainder of this, 15Z, what does that show?
This is the middle section of the unit. Behind this photo would be the Pyxis machine that we just looked at.
Okay. And 15AA, what is that?
This would be around the emergency department entrance of the Mount Carmel West Hospital.
All right. Mr. Rudman, those photographs that I just showed you, States Exhibit 15B through 15BB, do those show the hospital in the same or similar condition as when you worked there?
Yes,
True and accurate copy of what you saw in those working days?
yes.
So let's continue talking a little bit about the Pixis machine, Mr. Rudman. So who enters the actual order for the medication?
So the physician can enter the order through the computer. We can also take verbal orders and enter the order through the computer as well.
So if you take a verbal order as the nurse, which computer do you enter that medication order at?
Any computer in the unit can be used to do that.
Including the one on the Pixis machine?
No.
Okay.
So that's specific to the Pixis. The computer in the room or at the nurse's stations could be used to chart and enter orders. The Pixis machine was a dedicated piece of equipment.
All right. So if you would get a verbal order, when would you typically, as the nurse, enter that order into the computer? Before you withdraw the medication, after the medication, somewhere else?
It depended on the situation.
Okay,
If it
explain
was-
that to us, please.
If it was an emergent situation, we would withdraw the medication, take care of the patient, and then enter the order after the medication was given.
Okay, and if it's in a non-emergent situation?
Usually the physician would enter that order as a scheduled order, and it would be in the computer put in by whatever physician that ordered it.
How would you be alerted to one that the doctor would enter?
It would show up as a timed administration or as a PRN or as needed medication in our MAR or medical administration record.
All right, so explain to me what as needed means to you as the nurse.
So as needed was oftentimes used for pain medications. If the patient was in pain, we would sometimes have standing orders for Tylenol or various medications for pain, or even if a patient had a fever, we would have PRN orders or standing orders that we could use as needed.
Okay? And in those situations, does that mean you don't have to wait for a new order from the doctor?
Correct.
We've also heard a lot about obtaining medication via an override in the Pixis. Does that mean anything to you?
Yes, it was very common in the Mount Carmel health system for overrides.
Okay, so explain what you mean by override when you say it.
An override would be any time that you would override the Pixis to withdraw medication for any given patient. If you didn't have an order, or for some instances, there were also pieces of equipment or sterile water, saline that were in the large sections of the Pixis that wouldn't necessarily have an order, but we would have to override to access that.
And when you're referring to override, does that mean anybody else is reviewing that prior to you pulling it?
Prior to?
Correct.
Not always.
Okay,
If it were in an emergent situation and we pulled the medication, it would potentially be reviewed after we had given the medication.
and reviewed by who, sir?
Pharmacist and the physician.
So what is your understanding that of what the pharmacy does when you pull medication from a Pixis machine on override?
My understanding of their job, I don't really know their exact
That's fair.
protocols associated with that.
Okay. What if you wait for their approval? Tell us how that happens.
Within a medical administration record, when an order is placed by a physician or by a nurse, the pharmacist will electronically review the medication, such as an antibiotic. They might check for allergies or that the dosages are appropriate for the patient, and they could approve or deny the order.
Okay. How do you get notified of whether it's approved or denied?
Within the MAR, medical administration record, it would show as an approved by the specific pharmacist that did that or denied.
So tell us what you're doing if you're entering a medication and then waiting for pharmacy. Where are you at and what are you looking at?
Depending on how busy we were. If it were a non-emergent medication, we might be attending another patient, assisting with another nurse, or potentially charting at that time.
Okay. And then how do you know it's been approved or denied?
We would have to check the MAR
Okay.
to verify that.
So you'd have to physically go into that patient's record, look at the MAR to know it.
Correct.
Did you ever have a situation where the pharmacist would call you about a medication order?
They could. I don't remember any specific time for myself as a
Okay.
nurse.
You talked about obtaining via an override, medication via an override in an emergency situation. What was your understanding of what an emergency situation would be?
An emergency situation would really be any situation where the waiting for any period of time could potentially harm the patient in any way.
Was there a crash cart that was available for any code blue?
There were several crash carts on every unit in the hospital.
Explain to us what would be on the crash cart.
Crash cart would hold a monitor, defibrillator, also medications that would be used in code situations or emergent situations, including saline bags, suction equipment, really anything pertaining to a code blue situation.
Would there be any medication on that crash cart?
Yes.
What kind of medication would be on that crash cart?
Medications such as amiodarone, epinephrine, really any medication that would be used in a code blue situation, and then the pharmacist would have access to that to help mix any solutions that were needed, such as Levophed or other drip medications such as those.
Okay, so those medications you talked about, Levophed, what is that used for?
Levophed was used as a medication when a patient were in shock, blood pressure was dropping, the vessels would constrict down, which would increase the blood pressure for the patient.
Is that what we have heard called a vasopressor?
Yes.
Okay. The
Hold
epinephrine.
on. You mentioned 3 drugs. Can you spell them? This isn't a test, okay? But this poor young lady's taking it down, so I was just getting the spellings for her.
We'll start with Levophed, Levophed, and amiodarone, Amioradone, I believe.
It's okay, this isn't a test.
And then, what was the third medication?
Epinephrine.
Epinephrine. Epipherine.
She types phonetically, so helping her with the spelling is something that I
Sure.
try to do. No, I'm sorry for
No,
interrupting you.
that's perfectly fine, Your Honor.
I just want to keep her happy.
So what's epinephrine used for in a code blue situation?
Epinephrine is basically adrenaline, so it can be used to help jumpstart the heart when cardiac arrest occurs.
Okay, and the other one,
Amiodarone.
That one.
Is an antiarrhythmic.
Okay.
So it can be used when the heart is beating, but in various erratic heartbeats. It can be used to correct that into a normal, what's called a sinus rhythm or a normal heart rate.
Okay. Mr. Rudman, you've had some involvement in your role as a nurse with some of our victims in this case. So I'm going to direct your attention first to, and I'm going to start with Melissa, to what I've labeled as 14G, Can you identify which patient this is regarding, sir?
Melissa Pennix,
And her admit date was what date, sir?
11/15/2018,
And discharge date?
11/20/2018.
Okay. And I'm only going to direct your attention to your involvement with Ms. Pennix. So, and is that big enough for everybody to see? Okay. So in the middle of the page here, is that your name at the bottom?
Yes.
And what date were you involved with Ms. Pennix on?
11/18/2018.
And what was your involvement at this time? And I don't think I asked you, did you work a specific shift during your time at Mount Carmel West?
Yes. Night shift,
And what hours were those, sir?
7 p.m. to 7 a.m.
And when you were specifically in the ICU, were there specific doctors you worked with?
In the ICU or as rapid response?
First as the ICU.
ICU, it depended on what service was on for the given patient.
Okay.
For the general ICU, it was either Dr. Husel or Dr. Hagers most nights.
Okay. So directing when you were in the rapid response team, you responded to the entire hospital?
Yes, ma'am.
So I'm not even going to ask how many doctors you interacted with.
Probably can't count that high.
Okay. All right. Tell us about your involvement with Ms. Pennix, sir.
So I was rapid response. From my note, it looks like I was called to bedside to assess a patient who was hypoxic or wasn't receiving enough oxygen.
Okay. Thank you.
When I arrived, patient was on a large amount of oxygen. They ordered ABG, or arterial blood gas,
You're good. Go ahead.
and a chest x-ray to assess the patient. The chest x-ray showed interstitial infiltrate, which could mean pneumonia
Okay.
or some sort of respiratory issue
Okay.
going on with the patient. And then the arterial blood gas, as listed, from my recollection of reading ABGs, it's been a while, but
Okay.
it appears that she wasn't receiving enough oxygen and she wasn't breathing out enough CO2 to make her acidotic.
All right. And at this point, you indicate you're going to continue to monitor these symptoms?
BiPAP was placed.
What's BiPAP?
Which is essentially oxygen with pressure behind it, so it would
Okay.
help open the airway and deliver a higher concentration of oxygen.
Okay.
It's a step in between intubation.
Okay. And then I'm going to direct your attention to the next page. Again, is that your name?
Yes, ma'am.
What date is this involvement with Ms. Pennix?
The 19th.
So the very next day. What was your involvement with her at this point?
Looks like I was called back to bedside to assess the same patient, still struggling with the oxygenation even with the BiPAP that was placed. Again, we did another ABG, which did not improve from placing the BiPAP. And then at that point, I was in contact with the ICU charge nurse physician and decided to transfer to the unit.
Okay. And I notice it is the step-down ICU?
Yes.
So at this point, she's going into the ICU unit.
So you could go into the step-down ICU if potentially there were not enough beds in the main ICU.
Okay.
It could have been for that instance because there was no beds left.
Okay.
But it was, per my note, the step-down ICU.
Okay. Mr. Rudman, another patient you were involved with was Beverly Schertzinger. So I'm going to show you what's been marked for identification as States Exhibit 3C. And can you identify the patient for us?
Beverly Schertzinger,
And her admission date?
10/2/2017,
And her discharge date, sir?
10/9/2017.
And I'm going to direct your attention to the middle of the page here. Is that your name?
Yes, ma'am.
And what date was your involvement with Ms. Schertzinger?
So again, I was in my rapid response role. I was called by the standard floor to assess the patient who was hypotensive or low blood pressure.
Okay.
The vital signs when I arrived, blood pressure, obviously 84/47, which is low. She had had a liver biopsy prior to my arrival, and she presented with back pain and a rigid abdomen. They did a stat CT of the abdomen, which is an x-ray essentially, just a more in-depth x-ray. And it showed a small hemoperitoneum, which could be indicative of blood in the abdomen.
Okay. Go ahead.
So Dr. Mangan, who was the physician on the normal floor on that given night, they ordered a CBC, which essentially just looked at what her blood levels, her hemoglobin levels were, and then also placed a catheter to assess her urine output.
Okay.
Looks like her blood pressure dropped. A 1-liter bolus of saline, which is essentially fluid just to bring the blood pressure up, was given at that time. And the hemoglobin, which is a count of your red blood cells, were decreased, which suggested potentially a bleed from the liver biopsy.
All right. What else did you do?
Levofed was initiated because of the low blood pressure, 64/38. And anytime Levofed is initiated on the floor, it has to be the patient has to be transferred to the ICU for monitoring.
Why is that?
The floor nursing, they're not trained or able to keep a patient with Levofed on the standard nursing floors.
Okay. So what happened next?
It looks like we increased the Levofed as much as we could. No improvement. Patient was intubated at the bedside on the standard floor. And at that time, a code blue was called because the patient lost her heart rate, her pulse. We did 2 rounds of CPR and then transferred her to the ICU. At that time, the family decided to withdraw care.
Do you remember this patient at all, sir?
I do not.
So this is all from the medical records?
Correct.
So do you remember whether or not you were at the bedside at the time the family decided to withdraw care?
I'm not sure.
Okay. And in this note, does it note whether you were involved in the administration of any medication for her at the time they withdrew care?
Not in the note, no.
And if you had been involved, would there have been a note regarding that?
Usually, yes.
Okay. All right, so the last patient I want to talk to you about is Ryan Hayes. And this is State's Exhibit 2E. Can you identify the patient for us, sir?
Ryan Hayes,
And his admission date
4/2/2017,
and his discharge date?
4/4/2017.
And Mr. Rudman, fair to say you're very familiar with this patient.
Yes.
Why is that, sir?
This was the patient where I administer medications and was the subject of the nursing board hearing.
Okay. So let's talk about,
No, ongoing, good.
I'm sorry?
Just my ongoing.
Okay.
all right, I want to direct your attention to April 3rd of 2017, which is our medication order we're going to talk about. What was your role in the hospital on this date?
Rapid response.
So what happened that called you to the bedside at this point?
In this instance, the ICU called me because they were very busy, as they were most nights. The patient, or the nurse in charge of Mr. Hayes, was getting an admission from the emergency department for a full arrest.
And do you recall who that nurse was?
Tyler Springer.
Okay, so what happened when you got up there as rapid response nurse?
I met Dr. Husel and Tyler Springer at the Pixis, where I received a brief report about the patient and the orders given for the palliative withdrawal.
Okay.
And the explanation that they had another patient to attend to.
Okay, and what were the orders you were given for the palliative withdrawal medication?
1,000 of fentanyl,
Okay.
10 of Versed, and 10 of Dilaudid.
Okay, and did you withdraw those from the Pixis machine, sir?
I withdrew part of the order.
Okay.
Tyler Springer had initially began withdrawing when I took over assistance.
Okay. So at the top, this would be the order for the 1,000 micrograms of fentanyl,
Correct.
and it says IV push. What does that mean to you, sir?
Given intravenously, IV as a push rather than a slow drip through a bag of medication.
Do you recall how many vials of fentanyl you would have had to withdraw to meet the 1,000 micrograms?
I don't.
Okay. And then I'm going to direct your attention to the next order on the page. What is this, sir?
Hydromorphone or Dilaudid.
Okay, and how much of this were you to withdraw?
10 milligrams.
And on the next page, what is this?
Midazolam or Versed.
Okay, and how much did you withdraw of this?
10 milligrams.
And approximately what time did all of this happen on April 3rd, 2017?
It looks like around 22:53 per the records.
So once you withdrew this medication, Mr. Rudman, what did you do with it from there?
After I withdrew the medication, I met family at bedside and withdrew the medications from the vials, medicated Mr. Hayes with the medications that were ordered, and then extubated the patient per the orders and the family's wishes.
How many syringes would you have had to have used, sir, if you remember?
I don't remember.
Okay. Would all have gone into one syringe, or would you have done them separately?
Objection, said he doesn't remember.
I will permit it.
I don't remember.
Okay.
Usually it would be separate.
Okay.
Objection, move to strike the anything after I don't remember.
I'll permit it to stand overruled.
And Mr. Rudman, you withdrew these upon the order of Dr. Husel?
Correct.
Did you in fact administer these medications to Ryan Hayes at that time?
Yes.
Now, you had just come to the floor. At any point, did you have the opportunity to check Mr. Hayes' medical records?
I did not.
Did you, prior to administering these medications, enter any type of pain score into the system?
I did.
Okay. And I'm going to direct your attention to the next page. Can you show us where you entered the pain score?
It was 4/3/2017 at 22:57.
And you entered a 10 at that time.
Correct.
At any point, did you review prior to that the last 2 days' worth of pain scores that showed 0?
I don't recall.
Okay. Do you recall what Mr. Hayes' injury was, why he was there in the ICU?
I received a report by Tyler Springer, the nurse, and Dr. Husel prior to administration of the medications that he was a 39-year-old male with polysubstance abuse history. He was found down by a family member in the bathroom after an undetermined amount of time. When EMS was called, they did multiple rounds of CPR, eventually brought him to Mount Carmel West, where he was resuscitated again in the emergency room and then transferred to the ICU. So
That's the information you had.
anoxic brain injury related to a drug overdose was the information I had.
Why did you put the pain score of 10 in there, sir?
In hindsight, with the
Objection, Your
CPOT,
Honor.
Okay. The question is why, it's sustained. The question is why did you put the 10 down?
for the pain scale, we were taught as nurses that palliative extubations, the process of dying, was a very painful event. So we were putting pain scales as anticipatory pain for comfort care related to palliative extubations.
So this 10 is anticipatory.
Correct.
Now, the CPOT, is that the instrument you used in regards to this?
Correct.
Are you aware that that only goes up to a pain score of 8?
Yes, ma'am.
Okay, then why the 10?
In haste, it was an error.
Okay.
I was going for the maximum pain level.
Other than anticipatory pain, did you see any other indication of pain in Ryan Hayes before you administered these medications?
I don't remember.
Okay. The fentanyl, what type of medication is that?
An opiate?
And the hydromorphone?
An opiate?
And the midazolam?
Sedative?
Now, when you pulled these medications from the Pennix, did you await pharmacy approval?
I did not.
So you pulled these via an override?
Correct.
Why would you do that when typically you wait for pharmacy approval unless it's an emergency?
Really, any time I was called, it was of some urgency, as I was the only nurse as a rapid response at any given time. So if a code blue were to be called, that would be where I would have to go, and it could be across the hospital at any given time. In this instance, the family had traveled all day and were at bedside because some loved ones were coming from out of town, and it was a palliative extubation that was planned during the day but was completed at night because of that family dynamic.
So in your eyes, this was an emergency?
Yes.
Your Honor, if I can have a moment?
Yes.
Mr. Rudman, do you see Dr. Husel in the courtroom here today?
Yes.
Could you please point to him and
Stipulate to identification.
Okay.
Okay. Again, they're agreeing that he would identify Mr. Husel, so.
Thank you, Mr. Rudman. I have no further questions, Your Honor.
Ms. Menashe?
Thank you. One moment. Oh, are you? Oh, I'm sorry. Do you need the photos? No. Sure, I'll have the photos. Good morning.
Morning.
Diane Menashe on behalf of Dr. Husel.
Nice to meet you.
Nice to meet you. Just want to, got some follow-up questions, as you might imagine. I'll start from where you ended, if we could. Fair to say that when you were called as a rapid response nurse to the ICU with respect to Mr. Hayes, you understood that it was a palliative extubation.
Yes.
And you just testified to that it is your understanding that the decision had been made by Mr. Hayes' family to palliatively extubate him during the daytime shift.
Yes.
And that there was a pause or a gap in time between the decision and the night shift because family members or a family member was coming from out of state.
That's correct.
When you were at the Pixis machine with Mr. Springer and Dr. Husel, you were then, as you testified to, provided with some information with respect to what medication had been ordered for the extubation. Is that correct?
Yes.
Fair to say that your intent at the time in administering the 1,000 of fentanyl and the 10 of Versed and the 10 of Dilaudid was to provide comfort to the patient.
Yes.
I want to go back to the Mars with respect to Mr. Hayes, if we could. In preparation for your testimony today, did you have an opportunity to review the entire medical administration record for Mr. Hayes?
Yes.
And I just wanted to ask you some follow-up, because while you testified that in hindsight it was an error to write the 10, you're aware, are you not, that after the 1,000 and the 10 were administered by you, that a different nurse actually indicated that that medication had not relieved the pain of Mr. Hayes?
After reviewing, yes. I was not present during that administration.
But now, and I'm asking this because of your answer on direct, you are now aware, are you not, that a totally separate nurse, Nurse Springer, is that fair to say?
Yes.
Had indicated actually on the Mars that the 1,000 of fentanyl, the 10 of Versed, and the 10 of Dilaudid had not relieved Mr. Hayes' pain.
That's correct.
And that was actually indicated as a pain relieved no. Would you agree with me?
Yes.
And I'm just generally about Nurse Springer. I know you've been asked about this previously. Fair to say that that's a nurse that you trusted?
Yes. I actually went to school with him.
You went to school, and I think I remember also that you did orientation together. Is that fair?
We started at the same time.
And so someone that when you worked with him, you had no reason to doubt his credibility or the things that he might say or do?
No.
If I could, tell me with respect to, and I'm trying to just, showing you what's previously been marked as States Exhibit 2E. When you are entering in the pain scale, and you were shown this on direct, does this look familiar?
Correct.
10 is noted multiple times by you. Do you see that at 2257?
Yes.
Okay. And is 10, is that something that you manually entered?
Yes.
Fair to say that in your career as either a rapid response nurse or an ICU nurse, this isn't the only time that you've ever entered a 10?
Correct.
And just so we're clear, there's a little number 11 and a number 12 here. If you know, what do those indicate?
I'm not sure.
Okay. And you reviewed this document in advance of your testimony today?
Yes.
And would you agree with me that the entries from Nurse Springer are 19 minutes after the indication that you put as a 10? Would you agree with me on that?
Yes.
And tell the members of the jury, fair to say that like 15-minute checks are kind of standard operating procedure, is that right?
Yes, after pain medication administration.
After pain medication administration, then there's like 15-minute checks to see if the medication's working or if it's not.
Yes.
You had mentioned that Mr. Hayes had anoxic brain injury and was an overdose situation. Is that correct?
Yes.
And also, I just wanted to note one other thing, if we could, going back to this. I know you testified on direct that by entering a 10 into the system, you consider that like anticipatory pain, right?
Yes.
And would you agree with me that anticipatory means I'm doing something in advance of something else that might happen?
Yes.
Okay. And so I just want to make sure that we're clear here that the order date and time for the fentanyl was 2253. Is that correct?
Yes.
Okay. And your last updated, and it indicates 2253.
Yes.
And then if we can go to the pain charge, it's 2257 that you enter 10.
Yes.
You mentioned with respect to Mr. Hayes that you were called to ICU, and I wrote down, because the ICU was very busy, as it was most nights. Let's talk about the night of when you were called for Mr. Hayes. ICU was busy that night. Tell me, you don't remember the number of beds in ICU, correct?
Correct.
But fair to say that sometimes, even during the night, that the ICU was so full that someone might first have to wait to get to the ICU and go to step down.
Yes.
And the night of Mr. Hayes being a busy night in the ICU, that is not unusual.
No.
And in addition to the nurses and charging nurses and the physician on the ICU, there was always the capability of someone at the ICU also calling a rapid response nurse, such as yourself, correct?
Yes.
There's kind of lights are on the ICU at night, is that fair to say?
Yeah.
Things are active.
Very busy.
I want to talk about, if we can, Beverly Schertzinger. Showing you what's been marked as State's Exhibit 3C. Fair to say that, absent your review of these medical records, you have no independent recollection of this patient, do you?
I do not.
And did you review her entire medical record in preparation for your testimony?
Not the entire record.
The testimony you gave with respect to Ms. Schertzinger, your involvement was prior to her getting to ICU, or was it both before and after she got to ICU?
Before and after.
Okay, so I want to talk to you about showing you what's been marked as Joint Exhibit 3, page 817. First of all, just generally, what does this sheet appear to you if you recognize this type of document?
These would be the code notes.
And who fills out the code notes?
A nurse, usually.
Is this your signature right here?
Yes, ma'am.
And so before I asked you questions about it, I wanted to make sure that that's your signature. Can the jurors still see? Great. So does it appear that this code sheet relates to patient Schertzinger?
Yes.
I want to just go through it if we can together. The date is 8/9 of 17.
It looks like 10/9.
I'm sorry, 10/9 of 17.
Yes.
And the time of the code appears to be what?
21:56.
So, and obviously that's military time. Tell me what non-military time would be.
It's been a while. I believe that was 9:56.
And so we're talking night shift.
Yes.
And does it appear, based on the note over here, that as of this time of day, so at 9:56 at night, she is in the ICU?
Yes.
If you can, fair to say, Dr. Husel is the physician's signature down here on this code sheet.
Yes.
Talk me through at 21:56 what's happening on this code sheet.
At 21:56, looks like CPR was started. The patient was in PEA, or pulseless electrical activity. There was no pulse.
Okay, get a little volume.
1 milligram of epinephrine was administered. The patient was intubated and started on Levophed and vasopressin.
Okay, so let me walk you through this. This right here, the 1 milligram of epinephrine, that's to help someone live, right?
Correct.
And the same thing about them being intubated, right? That's a life-saving measure as well, is it not?
Correct.
And then it looks as if the levo, the vasopressors were increased. Is that a fair summary of what's over here?
Yes.
And then, does it look like 2 minutes later, those life-saving measures, her heart rate actually drops? Would you agree with me on that?
Yes.
And then we've got 2 minutes later after that, her heart rate is still at that 68?
Yes.
And so what, if any, life-saving measures are done under the guidance of Dr. Husel at that time?
An additional dose of epinephrine.
And then it's hard to read this, but fair to assume this last number is later in time?
Yes.
And it looks like from that epinephrine dose that her heart rate increases?
That's correct.
And what's this note over here, if you can decipher that?
The heart rate was picked up via a Doppler, which was a machine that we used with weak pulses, weak heart rates during code situations, and then the blood pressure was taken on the left arm.
So, and do you have any independent recollection of this event?
No.
When there's a physician signature on a code, fair to assume the physician is in the room calling the code.
Yes.
Is that right? Tell me visually, or tell the jurors more importantly, how that works. Code blue is called. Who's in the room?
A lot of people. Usually the physician, Dr. Husel, any nurses, respiratory therapist, pharmacist. Usually the family members are escorted out at that time, and all hands on deck situation essentially.
An all hands on deck situation, because fair to say everyone in the room knows that that person might die right then.
Yes.
Chaotic?
Can be.
And this last note right here, when it goes, this patient's heart rate goes to a 74, Doppler reads it, and a blood pressure is indicated on her left arm. She lives.
Correct.
And this moment, right, where her life is saved, is approximately 2200 on 10/19/17. Would you agree with me?
Yes.
And I want to take you back, 10/9, sorry. Take you back to State's Exhibit 3C. Later that night is when she passes.
Correct.
How many codes, if you recall, and an estimate was good, did you participate in with Dr. Husel during your time at Mount Carmel West?
A lot. I couldn't put a number on it.
And just because I'm a lawyer, I'm going to ask for a number generally. More than 20, less than 20, more than 50?
I would guess more than 50.
So more than 50 times in your time as either a response nurse or as an ICU nurse, you were in a room with Dr. Husel when he is coding patients and trying to save their lives.
Yes.
And saving their lives.
Yes.
I want to talk about patient Melissa Pennix. You were shown State's Exhibit 14G. Just want to confirm that your involvement with Ms. Pennix was not in the ICU. Is that correct?
Correct.
Okay. And so, given that it wasn't in the ICU, it had nothing to do with Dr. Husel.
In these situations, I oftentimes called the ICU, Dr. Husel included, to essentially put them on his radar, ask for his assistance or guidance at that time. and facilitate the transfer to the ICU. I would be with them the whole way.
And this is why on direct, Ms. Sawyer said that you're good, because I was going to ask you a question about, did you sometimes call Dr. Husel before a patient even got to ICU and say, hey,
Is there a question here?
yes, hey, you called him at times, did you not, and say, patient's on the way, have a heads up for this patient?
Yes.
And there were times even before a patient got to the ICU where you might call him for advice or bounce a question off him as well. Is that correct?
Yes.
And when you would make those calls to him, fair to say that he was approachable,
Yes.
accessible,
Yes.
willing to take the time to listen to the question and answer it?
Yes.
You were asked about the shifts, 7 p.m. to 7 a.m. I know was your shift. As a matter of practice, when the shifts would change between the nurses, was there, or wasn't there like a huddle where the night shift would talk to the day shift nurses and ensure there isn't a gap in care?
Are you talking general ICU?
Yes, general ICU.
Yes. We would get bedside report from the day shift nurse that cared for the patients that we were assigned that night.
And purpose, based on your experience, is so that despite the shift change happening, the patients continue to get constant care.
Correct.
And that was a part of those huddles or those, the exchange of information was a regular practice within the ICU, was it
Yes.
not? I know you were asked a lot of questions about what you consider to be an emergency. I noted that you indicated that as a rapid response nurse, kind of by definition, anytime you were called, it was an emergency.
Yes.
And part of your title as a rapid response nurse is rapid, right? So you come quickly.
Yes.
Overrides were a common thing within Mount Carmel West during your time there?
Yes.
I noted, in fact, that on your direct, you indicated that they were very common.
Yes.
Speaking of overrides, though, I know that you've been interviewed by police in this case, correct?
Yes.
And I know at one point that you had a deposition. Isn't it true that you were asked the question about your practice or you using overrides in relation to Dr. Husel? Do you remember being asked about that?
Not exactly, but
Okay, let me ask this. Fair to say that any override that you ever entered into the system was not at the direction of Dr. Husel?
no.
That is fair to say?
Yes, that is fair to say. Sorry.
That's okay. I just want to make sure we're clear. As a nurse, rapid response or ICU, fair to say you rely on your school,
Yes.
other trained nurses that you're working with, your peers,
Yes.
your own personal experience,
Yes.
and the physicians that surround you.
Yes.
All of those things come into play when you're doing your job on a daily basis.
Yes. Oh, sorry.
There was just a question about the step-down ICU, and just to be clear, Dr. Husel did not work in the step-down ICU, is that correct?
Yes, he would.
Oh, he would work in the step-down?
Yes.
And what years was that, if you recall?
I don't remember the exact year it was initiated, but I would say that at least through 2017 to 2019, or 2018, I guess.
And the step-down at that time was on a different floor or same floor?
Different floor.
I've got some questions, some general questions, if I can. Let's talk about patient-specific. And those are just two words used together. Fair to say that in your experience and training, you believe that every patient is different?
Yes.
And when you, as a nurse, are treating and caring for a patient, it's individualized.
Yes.
You have to look at a number of different factors when determining what is appropriate as to how to treat a patient.
Yes.
And I'm sorry, I just have to speak.
Yes.
And,
Sorry.
and the same is true, how many palliative extubations have you been involved in your career?
It would be an estimate. I would guess over 50.
And palliative extubations at Mount Carmel West could occur during the day shift and also during the night shift. Is that true?
Yes.
And of the 50 approximate palliative extubations that you've been a part of, fair to say that those are also patient-specific in terms of what's appropriate with respect to dosages?
Yes.
And you've worked, obviously, in those situations with a number of doctors, ICU physicians.
Yes.
And wouldn't you agree with me that even physicians do things differently?
Yes.
In fact, I know that Dr. Husel was on the night shift with Dr. Hagris, and they did things differently, did they not?
Yes.
But at the time, you both found them both to be smart doctors.
Yes.
In these situations where you've been part of a palliative extubation, there's a discussion with the family.
Yes.
And at Mount Carmel West, isn't it true that oftentimes there's a chaplain that comes and is involved in the discussion?
Yes.
Going specifically back to the Ryan Hayes matter, there wasn't a family discussion with Dr. Husel with respect to Mr. Hayes because that decision had already been made on the day shift.
I believe so.
When you administered the order for Mr. Hayes, where was Dr. Husel?
He was assisting with Tyler Springer in the fresh admit from the emergency department.
Because there was another patient at that very moment that was in critical condition, was there not?
Yes.
And that's kind of part of this busy nature of the ICU, right? It could be one patient that you could lose and another patient you could be losing simultaneously.
Yes.
I forgot to ask you something about Beverly, if I could just go back to Ms. Schertzinger. One moment. Because I remember the questioning about there's the front side and the back side of ICU. Do you remember those questions?
Yes.
Just give me a second. Nursing station with room 9. Yes, that's where I'm going. One moment, sorry. Just going through my notes. You were asked these palliative extubations, 50 or so. Fair to say that sometimes they're not pretty.
Yes.
And I just need you to speak up a little bit. And in your experience in these palliative extubations, that patients can experience pain.
Yes.
And have you ever heard of the expression "a bad death"?
Objection, Your Honor.
I'll permit the answer. Have you ever heard that expression?
Yes.
And have you ever, in your experience as either a rapid response or an ICU nurse, seen a bad death?
Yes.
What does that, describe that?
As in his experience.
In your experience as a nurse?
Any time where the patient that has been withdrawn on is experiencing discomfort, agonal breathing, air hunger, physical distress, is what I characterize as a bad death.
And in your experience as a nurse, throughout those years, there are a number of times when the family members are in the room. Is
Yes.
that right? And seeing that, the air hunger, right? And air hunger is gasping for air. That kind of
Objection, Your Honor.
noise.
Sustained, let's ask the question, please.
Gasping for noise, is that
Yes.
fair?
Okay. It was sustained, you got half of a question there. Ask the new question.
Okay. And obviously, the family members are in the room, should they choose to be, during the extubation and after the patient is extubated.
Yes.
And when you've seen those bad deaths, and I'm not going to ask you to, of course, say any patient names, but do they stay with you?
Yes.
Where's the picture? No. One moment. I want to just talk to you about the nursing station. And then I will be done. One moment, please. Of course, it has to be the last photo. Showing you what's been marked as States Exhibit 15Z. This is a nursing station right here? Sorry.
Yes. Oftentimes the pharmacist would use that computer as well.
Thank you. And does it appear, I'll zoom in a little bit, that there's actually two monitors there?
Yes.
Based on your experience and time at Mount Carmel West, would sometimes a nurse and/or pharmacist sit there just if they weren't actively engaged in something else?
Yes.
And what does this room number look like here?
Room 9?
And this area right here, is this a traffic area? People would walk in and out from there?
Yes.
Just want to go back to, if we could, that code sheet I showed you with respect to patient Schertzinger, Joint Exhibit 3, page 118. The room number appears to be what for that patient?
Room 9?
So it's right there, right next to the nurse's station.
Yes.
And with respect to the nurse's station, if you recall, based on your experience as a nurse at Mount Carmel West, that if a patient is being palliative extubated in room 9, that I, as a nurse, could give the family some privacy and sit right here and monitor.
Yes.
And is that, in your experience, a practice that was done, that a nurse might leave and then monitor the situation from a terminal?
Yes, every room had a curtain that could be closed.
And was that a practice that you did?
Yes.
You did that. And tell us, when you're here during an extubation, what information you can see on the monitors as to what's going on in the room.
We still have access to heart rate, sometimes blood pressure from the nurse's station. At that time, the monitors are usually, in the rooms, are usually put on standby so that the family don't incessantly watch it.
And when they're put on standby, fair to say that the noise is also turned down so it doesn't distract the family?
Correct.
But you have full capability during your experience to monitor the situation from a terminal.
Yes.
And that would be something that you would have done during a situation like that, is it not?
Yes.
One moment, Your Honor. Nothing further. Thank you.
Okay, I assume you got more than 10 minutes?
No, I don't think I do, Your Honor.
Okay, then we'll sally forth.
Your exhibits? Sorry, I'll reorganize them.
That's all right. I'll give you a hard time later. Mr. Rudman, where did you learn or who taught you that agonal breathing is painful?
Nurses, charge nurses, physicians.
Okay. Are you aware of literature that says it's not painful?
I have seen that literature.
Okay. The code sheet, Diane, can I borrow that back from you? And I'm going to show you, this is Joint Exhibit 3, page 817. When there's a code going on, is this when you're using the code cart, the emergency cart?
Yes.
And epinephrine, the levopad, those would all be available on there.
Yes.
Would you ever use fentanyl in a code situation?
No.
Why?
We're trying to resuscitate a patient. That's not a medication used to resuscitate a patient.
What about midazolam?
No.
What about Versed?
No.
Why not those two?
Same reason.
Okay. And in regard specifically to Ms. Schertzinger, and I'm going to point your direct attention to 3C again and your involvement. So in this note, you talk about that code that we just looked at. Is that accurate?
Yes.
At that time, well, first off, are you familiar with what a DNRCC and a DNRCCA is?
Yes.
What's a DNRCCA?
A DNR-CCA is a code status that indicates that all life-saving measures will be applied up into cardiac arrest.
Okay. And a DNRCC?
Your Honor, I think it's beyond the scope.
Well, it goes to the medical records, I'll permit it.
DNRCC is?
Comfort care.
Okay. So in this situation, as you're administering CPR, are either of those statuses in effect for Ms. Schertzinger?
From my note, I'm unsure. I would assume it would be arrest.
So because you're doing CPR, at the most, it would be a DNRCCA?
Objection, Your Honor, leading.
It would be full code, excuse me.
Okay. So
Your Honor.
Okay,
Okay.
overruled.
So it would be full code, which means you go ahead and do
Correct.
the CPR. At the time, and at that point, you wouldn't be looking at fentanyl, midazolam, or Versed.
No.
What about when the family decides to withdraw care? Would that be when one of those statuses go into effect?
Yes.
So at that point, would life-saving measures be used?
Life-saving, no.
Thank you. No further questions, Your Honor.
Okay, you may step down. Let's take our break, ladies and gentlemen. Just hang tight for a second. I'm gonna get them in their break. I'll see you guys in 15 minutes.
All right.
Let's say 22. I'll give you 18 minutes. That way there's no flux to the bathroom. Very admonitions. I'll see you guys at 22.
Oh, and these are, the ones in house.
Yeah. Yep. Yeah. Right back through the obstacle course. Mr.
Okay, go ahead. Just let her get up. Ms. Sawyer, anything for the record?
No, Your Honor.
Ms. Menashe. Ms. Menashe, anything for the record? Okay. We're on break. Ladies and gentlemen, I hope you had a wonderful break. We're going to continue on the testimony. Ms. Sawyer, you're going to call your next witness.
Thank you, Your Honor. State call Tyler Springer to the stand.
Okay, so I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
Okay, well, don't you go and have a seat there. Get yourself comfortable. You've got an aerial mic there in front of you.
Okay.
Okay, I need you to state your name and spell it for me so that my court reporter can get used to your diction.
Gotcha. Tyler Springer, Tyler Spr.
Hold on, I know you got a little bit more than that.
Tyler Matthew Springer. Oh, okay. Okay, Tyler Springer.
Now you gotta spell your middle name since you threw it out there.
Okay. TYLERMATTHEW SPRINGER.
Can you hear him okay, Madam Court Reporter?
Yes, sir.
Y'all hearing him?
Yeah.
Okay.
Thank you, Your Honor. Mr. Springer, did you attend college?
Yes, ma'am.
And where did you go to college at?
Mount Carmel College of Nursing.
And what degree did you receive?
Bachelor's of Science of Nursing.
And when did you receive that, sir?
2014, I believe.
And after that, did you become licensed as a nurse?
Yes, ma'am.
When did that happen?
2000, I think sometime in 2014, like the end of 2014.
Were you employed after you received your RN?
Yes.
Where was that at, sir?
Mount Carmel West ICU,
And how long were you employed at Mount Carmel West?
5 years.
Okay, from what date to what date?
I'm not sure the dates, but 2015 to 2019, I believe.
And why did you leave?
We were let go by Mount Carmel.
Okay. And at some point, did you have to appear before the nursing board because of incidents at Mount Carmel?
Yes.
And did anything happen?
Well, I didn't know. I did not have to appear in front of the nursing board. There was just an agreement with them.
Okay. And what was that agreement with the nursing board?
Objection, Your Honor.
I'll permit it.
Go ahead and answer.
1 year license suspension with 2 year probation.
And when did that license suspension occur?
On my birthday, November 18th of last year.
Do you,
Or not last year, the year before that, sorry,
2020?
2020.
Okay. Do you currently have your license back?
Yes, ma'am.
And are you currently employed?
Yes.
And without saying where, what are you currently doing?
Pre-certification nursing, it's not anything that's directly patient care, more so just looking at clinical information.
Okay. Let's talk about your employment at Mount Carmel. You indicated that occurred sometime in 2015?
Yes.
And what were you doing at that time for Mount Carmel?
I was just an ICU registered nurse,
Okay. What were your job duties as an ICU nurse?
taking care of very sick patients that would come through.
And when you say taking care of, explain to us a little bit about what you would do in that position.
Based off of the situation that was occurring with the actual patients that came through, changing them, bathing them, doing whatever it is that they need as far as, if they need intubated or lined or anything like that, putting an A-line in or a large IV in the neck, things like that we would help assist with.
Okay, and you got a little bit of a low voice, so I'm going to remind you to speak up
Yep.
so everybody can hear. Did you work any particular shift as an ICU nurse?
In the beginning, I worked nights. It's more so generally, I would say if you're the low person on the totem pole, you don't really get to choose, but I started out on nights and then I ended up transitioning to days.
Do you remember approximately how long you were on the night shift?
I want to say in the beginning, it was probably the first year was all night shift, and then it started to kind of go back and forth. I'd work some days during the day, and then, if they needed help on nights, I would help pick up on nights or vice versa.
Okay. Fair to say throughout the time period you were at Mount Carmel, you still continued to work some night shifts then?
Yes.
We've heard a lot of testimony about obtaining medication and how nurses do that. Can you explain that to us also, what you would do in your experience?
You said with just obtaining medications?
Correct.
We would get it through the Pixis machine usually, or it was sent up via like a tube with the tube station from the pharmacy itself.
Okay. Tell us what you would have to do to access medication via the Pixis.
So they would put in an order in which you could go and you could get it out, or sometimes they didn't necessarily have it in, but if you, and sorry, I'm trying to think here because it's been a while. If they put the order in, you could still override the medication, or you could still override it even if they didn't put the actual order in itself into the actual system. I forget the system that they use particularly, but it could either be scheduled and you can go and get it, or sometimes you could override it despite if there is an order that had been given by a particular doctor.
All right, so you said if they put the order in. Who is they?
The doctors.
Okay, and they put it into the electronic medical record? That's what we've been calling it.
Yes.
All right. How would you know then that you were to go get the medication?
Sometimes there's like an icon that would show like review orders or whatever it was, and it would just show like, hey, this medication needs to be given, or you could look at the MAR. I don't know what the meaning of that is, but you could look there to see what medications could be ordered.
Okay. And you said sometimes they put it in, sometimes they don't. Again, the doctors?
Yes.
So that would be what we've been terming a verbal order?
Yes.
Right. You also mentioned getting it via override. Explain to us what you mean by that.
So basically, you could go to the Pixis machine, say you got a verbal order. You could go, and it actually happened all the time. We saw nurses do it all the time on day shift and on night shift.
Okay.
You could just go pick out whatever the medication it was that was ordered that you got a verbal for, and then you could withdraw it at that time from the Pixis via override. You can just look up the medication.
What's the difference between pulling it via override and not pulling it via override?
I don't recall.
Okay, that's fair. And you had said earlier, I could pull it via override or I could wait for them to approve it. Who's them in that case?
It would be pharmacy would be the person that I think would sign off on the medication or whatever was ordered.
And if there's an override, has pharmacy signed off on that medication?
Not necessarily.
Okay. Now, what is your understanding of pharmacy's role if you pull medication through an override?
That I don't recall.
Okay, that's fair too. It's been a while.
Right. Yes, ma'am.
Describe to us what the ICU at Mount Carmel looked like as far as how it was set up.
I would say it was shaped like a U.
Okay.
U-shaped.
How many nursing stations, for example?
Altogether, I believe there was 4, I believe.
Okay. How many floors did the ICU at Mount Carmel West consist of?
1 at the time.
Okay, so when you were in there, was it 1 floor?
Yes.
And you mentioned the Pixis machines. How many Pixis machines?
3.
All right. Mr. Springer, I'm going to start by talking to you about some of the patients you were involved with that we are here for right now. So, and I'm going to start with Belisari. Sure. Okay. I'm going to show you what's been marked for identification as State's Exhibit 1E. Can you tell us which patient we're talking about here today?
Joanne Belisari.
And what was her admit date?
Admission date was April 22nd, 2015,
And what date was she discharged from the hospital?
May 10th, 2015.
All right, so I want to talk to you specifically about your involvement. And I'm going to start with a note that you made on May 4th of 2015, and I'm going to direct your attention right there at the top, if it doesn't fall over on me, right? All right, can you tell us, is that your name up there at the top?
Yes, ma'am.
And what's the date and time of this order?
May 4th, 2015 at 4:18 in the morning.
What are you doing at this time with Ms. Belisari?
Can I read this?
Sure.
So it looks like we are changing over the tube from one side to the other. Typically, we would do that during the early morning hours before shift change.
Okay, you said tube. What are we talking about when you say tube?
Endotracheal tube, the intubation tube that goes into the actual lungs down through the throat.
So is Ms. Belisari on a ventilator at this point?
Yes.
Okay. And tell us about your involvement in changing the endotracheal tube at this point.
Basically, we're next to the patient, and we are changing it from left to right or right to left, whichever way it was.
Were there any issues that arose at this point?
Yes, so it appears that, from what I can read from here, that it looks like she became very agitated, biting down on the tube, so therefore she was more so awake, not going with the actual ventilator itself, being able to do its work, so therefore we weren't able to go from left to right, left to right. So therefore, she became agitated, and it looks like we ended up giving some medication to help calm her down.
Okay, what medication was administered?
It looks like fentanyl and Dilaudid.
Okay. And how much fentanyl was given at this point?
200 micrograms of fentanyl,
And how much Dilaudid?
1 milligram.
And Dilaudid is what as far as the actual medication?
I guess I don't understand the question, I'm sorry.
Is that midazolam?
No, it is not. It's an opioid medication.
So that's hydromorphine.
Yes, hydromorphine, yes.
All right, so this is May 4th, 2015 at 4:18.
Yes.
All right, I'm going to direct your attention over to the page where we talk about MAR, the medical administration record that you just talked about.
Okay.
All right, so middle of the page here. Would that be the 200 micrograms of fentanyl from that incident?
Not that I recall, no. 337. Yes.
Okay, and I note here you've got a pain score. What is the pain score you have at this point?
As an 8.
Okay, and then below that is the hydromorphone order,
Yes, ma'am.
and again, the pain score.
Is an 8.
And which doctor gave you these prescription orders?
Dr. Husel.
Did you administer those prescriptions?
Yes.
Did that resolve the issue with the pain score?
Not that I recall.
All right, what if I show you 5-4? Okay, I'm going to direct your attention at the top here.
Yes, it did resolve the pain, the pain and the agitation.
Okay, so after the 200 micrograms of fentanyl and the Dilaudid, what pain score does she now have?
0.
I don't have it. Sorry. Yeah, it's part of the face down, so I didn't have it on. So at least with Ms. Belisari, that 200 micrograms appeared to relieve the pain.
Yes.
I'm next going to direct your attention to James Allen. And I've marked this for identification as State's Exhibit 8D. And can you tell us who the patient is in this case?
Yes, James Allen,
And what date was he admitted to the hospital?
May 24, 2018,
And what date was he discharged, sir?
May 28, 2018.
All right, and unfortunately, you're in the middle of a list here, so
Okay.
I'm going to direct your attention, and I'm going to show you the top first. What is this? Can you explain what this direct charting flow sheet is for us? What's that mean to you as the nurse?
It just looks like the oxygen delivery and the pain score charting that would be in our charting system that we used.
Okay? And explain to us, what do you as the nurse assigned to a patient have to do as far as charting for any patient that you're caring for?
Normal assessments, we would just go in and we would, chart what they look like, the physical exams, the pain scores, if they had IVs, things like that. Does that answer the question?
Sure. And approximately how often, if you're on the night shift, you come on at 7 p.m.?
Yeah.
Leave at 7 a.m.?
Yes, ma'am.
So during that time period, how often would you check on these patients approximately?
Every 2 hours.
Okay. So I'm going to direct your attention to the middle here. And do you see your name in there?
Yes, ma'am.
All right. There's a laser pointer in front of you.
Okay.
Can you use that to point that out to the jury where you're at?
Right there.
All right. So what date is this on, sir?
May 26, 2018.
And looks like you're charting every 2 hours like you just told us.
Yep.
And what was the pain score that you gave Mr. Allen during your time period of involvement?
0.
What does that mean to us?
Well, more importantly, what does it mean to him?
All right, what does it mean to you, sir? Is he in any pain?
No.
Okay. And I see the words here, nasal cannula. Am I
Yes.
saying that correctly? What is
Yeah.
that?
It's just, it's a tube that goes into your nose, has little prongs, and it provides oxygen to the patient.
So at this point, Mr. Allen's not on a ventilator?
Correct.
All right, and then I'm going to direct your attention to the bottom of this same document. Let me show you this top level. What are you looking for in charting at this time?
Pain intensity scale, is pain level acceptable?
All right, I'm going to direct your attention to the very bottom. Is that you?
Yes.
And what is your finding regarding the acceptability of pain?
That they are having pain, yes.
Well, let me go back to the top.
Is pain level acceptable? Sorry. Yes.
Okay. Yeah, it's a little hard when the top
Sorry.
cuts it off, doesn't
Yeah,
it?
Sorry.
All right, and then going to the next page again, same thing as pain level acceptable. And is that again you at the top?
Yes, ma'am.
And your finding
Yes.
that it's acceptable?
Yes.
All right, and I want to just point out here, it's a reference to CPOT. What is that, sir?
That I don't know.
Okay.
It looks like it's a pain scale, pain intensity scale, but I don't recall. It's just been a long time, but I don't recall what tool
Okay.
or scale, I guess, we would use.
All right. Well, and let's go back just a minute. What type of training, when you started working at Mount Carmel, what type of training did you receive?
A lot.
Tell us about that.
It was just, there was a checklist. I can't recall everything. But basically, if there was a pain score, I was taught that there was a pain score of 0 to 10.
Okay. And then, was there any when you first started, set orientation or training that you had to go through at that time?
Yes.
Tell us about that a little bit.
You had a preceptor that you would follow around. I do recall that I had multiple ones. It wasn't just one. I know that they tried to keep you with the same person, but I do recall when I was there was multiple nurses that I followed that precepted me, per se. Taking care of different types of patients. They tried to do more so along the lines of cardiac patients, stroke patients, palliative patients, just different types of patients, and helping assist with putting an arterial line in or a large IV in the neck, or I don't know, there was a lot.
Okay. Was it a kind of sit down and you learn things, or did you learn on the job?
Learn on the job.
All right, so redirecting your attention back to Mr. Allen, and I'm going to talk Glasgow coma score. What's that mean to you?
I do not recall.
But that was something you used at Mount Carmel at the time?
From this, yes, it looks like it, yes.
All right, I'm going to... Do you see your name on here?
Yes, ma'am.
Can you point that out to us?
Yep. Right there.
All right, and what score was given?
14.
And then again with Mr. Allen, Richmond Agitation Scale, known as the RAS, I think.
Okay.
Do you remember that?
I do not recall.
But again,
It's just
something
been a
you
long
would have
time.
used during that time period?
Yes, I believe so.
All right, and I'm going to direct your attention to about the middle. Do you see your name on here?
Yes, ma'am.
All right, and can you point that out to us?
Yes. Right there.
All right, and it says C below T623, and it goes down to T770. Do you know what that means?
No idea.
All right. So I'm going to direct your attention. All right, and I see here at the bottom a T77 connected to the Richmond Agitation Scale, and that was the last number on your, do you remember that?
Yes.
All
I
right.
just saw yes.
What do you have here as the Richmond Agitation Scale?
Looks like drowsy, -1, not fully alert, but has sustained awakening.
Okay. And at least at the time you were doing this at Mount Carmel, you had been trained on that scale?
I do not recall.
Okay. All right, Mr. Springer, I'm going to direct your attention to State's Exhibit 2F. And what patient is this regarding?
Ryan Hayes.
And do you remember Ryan Hayes?
Yes.
Why do you remember him specifically?
Basically because it was probably the highest, amount of medication that I've given to someone. But also with the rise of all this, it's more so just been brought to my attention.
Okay. This was probably the patient you got disciplined for, or at least put on administrative leave
Your
for?
Honor, he's already answered the question.
I'll sustain. Let's move on.
What date was Ryan Hayes admitted to the hospital, sir?
April 2nd, 2017.
And what date was he discharged?
April 4th, 2017.
All right. All right. Mr. Springer, I'm going to direct your attention to the pain score area. Do you see your name on this?
Yes, ma'am.
Can you point that out to us?
Yep. Right there.
All right, so this would be on April 2nd, 2017?
Yes.
Night shift?
Day shift.
Day shift, all right.
No, yeah, night shift, sorry.
Okay. What pain score on April 2nd of 2017 in the night going into April 3rd in the early morning did you assign to Mr. Hayes?
0.
And then I'm going to direct your attention a little bit further down. Do you see your name on here?
Yes.
Can you point to it again for us?
Right there.
And what about a little further up?
Oh, there. 0.
Okay, and keep going down. Where's the next time you see you?
Right there.
Okay, what date is that on, sir?
4/3/2017.
At what time? I'm okay if you just say that.
1922.
There you go. And what other time?
2110. Yeah, 2110.
What pain score did you give Mr. Hayes at this time?
0.
Do you remember what 0 meant as far as a pain score?
Just no signs of pain.
Do you remember Mr. Hayes' condition at the time you were treating him?
I do. Is it more so like what brought him in, what
Okay,
came to the ICU?
absolutely.
Is that to answer your question?
Yes, what do you remember about him?
I know that he was a full arrest, came in through the ER, was found down. I think he was found down for about 10 minutes. He was in a bathtub, and basically they did multiple rounds of CPR, ACLS, to get him back to the hospital, or get him to the hospital, and then at the time he was transferred to the ICU somehow. I don't believe that I admitted him, but I know that he was intubated and on multiple medications, drip IV medications per se, if that answers your question.
Okay. Was he on any pain medication during the time period he had 0 pain scores?
I don't recall.
Okay. All right, I'm going to direct your attention to level of consciousness, CAM. What does this mean to us?
I don't recall what the CAM is, but if it's dealing with the level of consciousness, it's just seeing what their level of consciousness is, if that answers your question.
Sure. Do you see yourself on these?
Yes, I do.
Can you point those out to us?
Yeah, right there.
Okay, and what date is that on, sir?
April 2nd, 2017.
And what do you note as far as his level of consciousness for Mr. Hayes?
It's charted as comatose.
Okay. And do you see yourself on here anywhere else?
Yes.
And where is that, sir?
Right here.
What date is that on?
April 3rd, 2017.
And what is his level of consciousness at this point?
Comatose.
All right. Going to direct your attention to another page where it talks about cough reflex and gag reflex. What is that? What are you looking for with these two?
Their cough reflex or gag reflex.
Okay. Why is this important?
It's been a long time. I don't really recall.
Okay. Do you see your name on there, sir?
Yes.
And where is that? Can you point that out to us?
Yes, it is. Right here.
Okay, and what date is that?
April 2nd, 2017.
What did you find regarding the cough reflex
It was absent.
and the gag reflex?
It was absent.
And anywhere else that you see your name?
Yes, right there.
And what date is that?
April 3rd, 2017.
And what do you find regarding the cough reflex
Is absent.
and the gag reflex?
Absent.
Okay, do you remember a order for palliative withdrawal, palliative extubation of Mr. Hayes that occurred on April 3rd, 2017?
I recall that we were waiting for the son to arrive to make the decision for a palliative withdrawal.
Okay. What was your role regarding this palliative extubation?
The nurse that would potentially, if I was there when when the son was to arrive, to help with the palliative withdrawal. Nurses helped all the time, day and night, different patients.
Okay. Do you remember Troy Rudman coming up to assist with this?
Yes.
Tell us about that.
I do know that I recall that night, obviously we were waiting for the son to get there. I believe he arrived and made the decision to extubate, palliative withdrawal. And I was getting another patient in the room, a couple rooms down, I think. It was a full arrest. And I think that if I recall, he wanted to withdraw, and Troy was there to assist while I was to get my other patient kind of settled in and to get it to where they were stabilized to where I could get back into the room.
Okay, and did you get back into Mr. Hayes' room?
Yes.
And at that point, Did you receive a request for a medication order that you filled?
Yes.
And what date and time did this occur at?
April 3rd, 2017.
And who gave you the order?
Dr. Husel.
And I'm going to turn the page and direct your attention to the middle of the page here. How much fentanyl were you ordered to?
1,000 micrograms.
Do you recall how many vials of fentanyl that would be?
If I recall, 10.
Okay. And any other medication that you were ordered to draw at this time?
Looks like hydromorphone and midazolam.
All right, hydromorphone being the Dilaudid we've talked about before.
Yes, ma'am.
How many milligrams of Dilaudid?
10 milligrams.
And you said midazolam, how many milligrams of midazolam?
10 milligrams.
And again, what date and time were those two?
April 3rd, 2017 at 23:16.
So the fentanyl, the Dilaudid, and the Versed, all together for Mr. Hayes?
Yes.
Are you aware of whether or not Mr. Rudman had administered those exact same doses to Mr. Hayes about 20 minutes earlier?
I was not.
What did you do at this point? You were given these orders.
I would draw the medication up and go and give the medication to the patient
Okay, so you withdraw from where?
from the Pyxis.
And do you remember whether you awaited for approval from the pharmacy or did this via an override?
Override.
And then once you withdrew this medication, what did you do?
I went to my room, obviously got the verbal order. We put the order in. Actually, we put the order in, overrode, and then I got the medication out and went and administered to the patient.
To Mr. Hayes?
Yes.
Was Mr. Hayes already extubated at this time?
Yes.
So that was done prior to you arriving in the room?
Yes.
Was there any family there at that point?
I believe the son was there.
And you said you got the order. Who did you get the order from?
Dr. Husel.
All right, and Mr. Sprinter, I'm going to direct your attention back to, this is again 2F, patient records for Ryan Hayes, and this is the pain intensity score. Now, did you enter a pain intensity score at this time when you administered the 1,000 micrograms of fentanyl, the 10 milligrams of hydromorphone, and the 10 milligrams of Versed?
Yes.
What pain score did you give Mr. Hayes?
A 10.
What did you base that on?
I anticipated that he had pain. I know that he was turning blue. Also, you have to think, too, that with the compressions that he had and the healing process, he's probably going to have some pain with that as well.
Okay. Now, you said compressions from the CPR?
Yes, ma'am.
That he had before he even got to the hospital.
Yes.
But what pain score did you give him before that?
A 0.
Okay.
0.
Thank you. I have no further questions, Your Honor. Diane?
Bias? Or Mr. Nash, I'm sorry, I thought Mr. Bias was up, my fault.
You know, sometimes we mix it up.
They're right there, Diane.
Thank you. Appreciate it. Paula?
Yeah.
I am going to show the second page of the flow chart.
Okay.
On Alan that takes it to the other scores.
Sure. Okay. Did he do those?
No, but I'm going to show it to him.
I may object to that.
Okay.
Because, okay.
Good afternoon. Hi. Diane Menashe. Good morning. Good morning. Diane Menashe on behalf of Dr. Husel. Diane Marie Menashe.
Yeah, right.
I haven't said Marie in a long time.
Spelling it.
in that interview, you had indicated that there was kind of a hesitancy or hold with respect to Mr. Hayes, had you not? Because the day shift had called the son, and everyone was waiting for the son to arrive.
Yes.
And the son, as you indicated and recall, was he not the next of kin or power of attorney for Ryan Hayes?
Yes, ma'am.
And you indicated to police, correct, that the son was coming from North Carolina?
Yes.
And so that's 6, 7-ish hours from Columbus, Ohio. Would that be fair to say?
Fair to say?
And in that process, it's actually the hospital that called the son. Is that how you recall it?
I don't recall how I know that I didn't call, but I don't recall who actually called the son.
That was my next question. You weren't the one that called.
Correct.
But there is a pause waiting for the son to arrive.
Correct.
And the pause lingers into or goes into the night shift. Is that correct?
Yes.
And ultimately, the son arrives.
Yes.
Without going into what was said, fair to say that there was a lot of tension between the patient and the son.
Yes.
There was, when the son arrived, it was not a warm feeling that he exhibited, in your opinion, with respect to his father. Is that fair to say?
Yes.
And I asked this to determine what you did based on what was said, but isn't it true that when the son arrived, he said, pull the plug?
Yes.
And then that indicated a code status change?
Yes.
And then the medication orders were placed for the palliative extubation?
That I recall, yes. Well, it would have been, yes, we would have been told to actually palliative extubate, yes.
And ultimately, as the next of kin or power of attorney, if you know based on your experience that he was the one that, the son, was the one that had to make that final decision.
Yes, ma'am.
I want to talk about, we'll go through the Ryan Hayes records. Showing you what's been marked as State's Exhibit 2F. I remember in your December of 2018 interview, you said, did you not, that you had done a significant number of palliative withdrawals?
Yes.
I think you indicated thousands, but how many had you done as of 2018, just in your course of your career?
I don't recall the number, but I know that I had done multiple.
Okay. And so Mr. Hayes was not your first palliative extubation?
No, ma'am.
Showing you what's been marked is State's Exhibit 2F, and just to orient ourselves, fair to say this looks like the medical records you were shown for Ryan Hayes.
Yes, ma'am.
Just want to go through them if we could. With respect to, I'll just go right to the direct charting flow sheet. You were asked questions about your indication here on 4-2 that the pain score was 0. Do you see that?
Yes, ma'am.
And fair to say that 4-2 was the day that Mr. Hayes had arrived in a code situation as an overdose.
Yes.
And you talked about on your direct that when you were trained at Mount Carmel, you had extensive training. Do you remember that testimony?
Yes.
And fair is it not that you were trained that at Mount Carmel that the pain score was 0 to 10?
Yes.
Based on your training at Mount Carmel West as a nurse, fair to say 10 was the highest level of pain.
Yes.
And in your experience as a nurse, if you recall, were there times when you rated pain a 2?
Not that I recall, but
Okay. What about a 5?
Not that I recall, but potentially yes.
Okay, there's other numbers in between 0
Yeah,
and 10.
yes.
That's my point.
Yes.
And I will get to you and other numbers in a second. But you indicate a 0 here on 4/2, on the day that Mr. Hayes comes into the hospital. Would you agree with me on that?
Yes.
And then down here on 4/3, you indicate 10 in 2 places at 23:16.
Yes.
Do you see the time there?
Yes, 23:16, yes.
Okay. And I think the point was made 0 to 10, but you would agree with me that more than 24 hours has passed between those differing pain scores?
Yes.
One moment, Your Honor, just ask for some. I want to go now to the fentanyl order that you were asked about on 4/3. Do you remember that line of questioning?
Yes.
And showing you here, I'm assuming that you had an opportunity to review the MAR record for Ryan Hayes in advance of your testimony today?
Yes.
And so it looks as if it does it not that Troy Rudman placed an order for fentanyl of 1,000 micrograms, and the time on that is 22:57.
Yes, ma'am.
And then I want to go down here to where it indicates this fentanyl order is, it indicates that your name is by that. Is that correct?
Yes, ma'am.
Okay. And what time does that appear to have been done?
23:16.
Okay, so how much time approximately was that after the order by Mr. Nurse Rudman was placed?
15 to 20 minutes.
Talk to us about, fair to say, pain as a matter of practice with respect to nurses is checked sometimes on a 15-minute interval. Is that fair to say?
It depends. It could depend on the patient's family. You know, you're checking more often, more frequently if they think that the patient's in pain, or Troy helped with palliative extubating. I wanted to go check on my patient to make sure, check on family, check on my patient, see how he was doing, per se, if that answers your question.
It does, because I remember in your interview with the police, you said, did you not, and I think you said, did you not, that you can't stress enough that your entire life, right, in your heart and with respect to your family, you've never wanted to harm anyone.
No.
And that was true on 4/4 of 2017, was it not?
True.
You wanted to provide comfort to Mr. Hayes.
Oh, absolutely.
And with that intent of providing comfort to Mr. Hayes, you put in this order for 1,000 micrograms of fentanyl. Would you agree with me on that?
Yes.
And you also spoke of the other order that you entered as well, in addition to the fentanyl.
Yes.
The question was asked if you had known about the administration of the previous 1,000.
No, I did not.
And you indicated you had not.
No, I had not. I do not recall it.
I want to go here and here. When you entered this order in, and you would agree with me that this is your name here,
Yes, ma'am.
that the pain scores indicated as 10.
Yes.
And that is after, in hindsight, we know that 1,000 micrograms of fentanyl was given.
I don't know how much was given, but I do know that, and you can't, I don't know if any medications were given at all. I don't recall any medications being given at all, but I do know that Troy had extubated him, and then I went, after I got my other patient, and checked on the patient. Well, Mr. Hayes.
So then this is, I think, maybe a more fair question. What we know is that when you arrived on scene and when you placed this order, you indicated that the pain score was a 10.
Yes, ma'am.
And then again, when you placed the Dilaudid order for 10 milligrams, you also indicated there, did you not, that the pain score was 10?
Yes, ma'am.
So at 23:16, pain score 10 for patient Ryan Hayes.
Yes.
Fair to say that at any point in time during your career, you wouldn't have input a 10 unless you believed at the moment it was a 10.
Yes.
Just need to speak up for the qual.
Yes.
I want to go to now talk about patient Joanne Belisari, showing you what's been marked as State's Exhibit 1E. Does that seem to indicate that those are the records you were shown with respect to Ms. Belisari?
Yes, ma'am.
I just note this so we can see it, but fair to say down here, this appears to be a pain response form from you, does it not?
Yes, ma'am.
And I just note that there are occasions when you note that the pain has been relieved from medication, do you not?
I'm sorry. Can you repeat the question?
Sure. There are times, as indicated by this medical record, when you note that pain has been relieved from the medication.
Yes.
You were asked specifically about this event on 5/4 of 2015.
Yes.
I want to scroll down because I don't expect you to memorize it. Ms. Belisari came to Mount Carmel West on 4/22,
Yes.
and her discharge date or date of passing, as we now know it, is 5/10.
Yes.
5/4 is kind of, it's in the middle a bit, right? It's 6 days from when she passed.
Yes.
So I want to focus on this because this 200 micrograms of fentanyl was an order placed by Dr. Husel.
That I don't recall.
Okay?
Yeah, it doesn't show it.
Okay, and that was your testimony on direct.
Oh, yes, yes.
Okay.
Yeah.
But I'm happy to show you.
There's a lot, sorry.
Don't be sorry. I'll go here if we could. Dr. William Husel, does that look familiar?
Yes.
Okay. And here's what I just want to ask about this, because the number, it was 200, was it not?
Yes.
And a milligram of Dilaudid, this man right here.
Yes.
And you were asked whether it actually relieved the pain or not. Remember those lines of questioning on direct?
Yes.
I just want to walk through the note together if we could. Patient became very agitated in changing the tube.
Yes.
Because changing the tube, that's the trach tube, is it not?
Yes, ma'am.
Can be painful.
Yes.
And you have seen that in your experience as a nurse.
Yes, I can recall multiple times where we would change. It's very uncomfortable, I would say.
And so to provide comfort to that patient, in your capacity as a nurse, an order of 200 micrograms of fentanyl and 1 milligram of Dilaudid was ordered by Dr. William Husel.
Yes.
Would you weren't asked about it, but would you agree that the note goes on to say, even with 200 and 1 milligram of Dilaudid, what does that next sentence say?
Still unable to change tube from right to left. Tube left on right side due to patient biting down on the tube.
And you would agree with me not, based on your experience as an ICU nurse, that patient biting down on the tube could be an expression or indication of pain?
Potentially.
Or discomfort.
Yes.
And that's after the 200 micrograms was given.
Right.
And notably, this event right here is when Ms. Belisari was on a ventilator,
Yes,
not when she's been extubated.
correct.
And you know what? Sometimes there's a method to my questioning. One moment while I pull this record up. The pages aren't numbered, Your Honor. No, I'm just explaining my delay. I'll just show it to you. I need this right here. No, just give me a second here. One moment, Your Honor. I want to find this. I had asked you earlier if you'd ever used numbers other than 1 and 10. Do you remember that?
Sure. Yes.
Directing your attention to this 200 micrograms of fentanyl that was ordered with by Dr. William Husel. Does that look familiar to you?
Yes.
I just note here, your order,
Yes.
you performed the administration of this medication,
Yes, ma'am.
and the pain score that you've indicated right there is what?
Is an 8.
Okay, let me... go back, if I can, to Mr. Ryan Hayes. I think also showing you what has previously been marked as State's Exhibit 2F. Also, just want to make sure, and I left this out, this is Mr. Hayes' MAR. Do you agree with me on that?
Yes.
Okay. And down here, where the fentanyl order was placed with respect to the 1,000 that you administered, would you also agree with me that the indication you've noted is pain relieved with medication, and you noted no?
Yes.
So that's separate and apart, is it not, that entry point from the 10 as a pain score?
Say that again, I'm sorry.
Pain score 10?
Yep.
You input that?
Yep.
And separate question, pain relieved with medication?
It says no.
Then going on, does it not, with respect to the MAR, it indicates that pain relieved with medication is continued to be no.
It says no, yes.
And then we've got the pain score 10 on the heels of the pain relieved with medication.
Yes.
I want to talk now about Mr. Allen, showing you what's been marked as State's Exhibit 8D. Does that appear to be the record of James Allen that you were shown on direct?
Yes.
Just want to go through some of the questions that you were asked about. And I just want to orient you, if it's okay. Showing you page 1, you were asked questions with respect to pain scales that you gave on this sheet. Would you agree with me on that?
Yes.
If I can flip to the next page, fair to say that based on the medical record...
Your Honor, I'm going to object. He's not anywhere in that area, and he's not after it, so it's not something he would have been able to even review in the course of his job.
Okay, so...
Let's rephrase.
when these pain scales are entered, Mr. Allen is not on a ventilator, is he?
No.
So, in your experience and training as an ICU nurse, a patient's condition can change drastically in the ICU, even between minutes, right?
Yes, ma'am.
And hours,
Yes, ma'am.
and days.
Yes, ma'am.
And when someone's on a ventilator, things can really change.
Oh, yeah, yes.
And that's with respect to pain, comfort, discomfort, all those things.
Yes, ma'am.
So I ask you, because you were asked on direct examination about the Glasgow coma score that you indicated right here on 526. Do you see that?
Yes.
Okay. But we know that Mr. Allen lived until 528.
Yes.
And fair to say that he was not on a ventilator on 526.
Yes, he was not.
And so would it surprise you, or would it be unusual based on your training and experience as an ICU nurse, that someone's Glasgow score could go down over the course of an hour, 2 days, or 24 hours?
I don't recall the Glasgow coma scale or Glasgow coma score, but I would say yes.
And isn't that kind of the point of charting periodically, is because in the ICU, things can change quickly?
Yes.
In your experience as an ICU nurse at Mount Carmel West working the night shift, do you recall an estimated number of times that you were in code situations with Dr. Husel?
I don't recall, but I mean, I worked, him and Hagris, I think, switched off on and off certain days, so it would just depend, but I can't recall.
Are codes something unusual or not unusual in the ICU?
I would say that they are usual. They can happen.
And because I think on direct you indicated that people in the ICU are very sick people.
Yes, ma'am.
And a code situation takes place when someone is actively dying?
Yes. Yes, ma'am.
And if a person comes out of code, then essentially their life has been saved.
Yes.
Would you agree with me that during your time as a nurse at Mount Carmel West, as an ICU nurse, that when determining whether an order was appropriate, you relied on your education? Correct?
Yeah.
Your prior experience?
Yes.
Input or experiences with your peers, your fellow nurses?
Yes.
And also input and time spent with physicians that work with you.
Yes, ma'am.
You relied cumulatively on all those things when you were determining whether a dose or patient care was appropriate.
Yes.
And just so we're clear with respect to the Brian Hayes order of 1,000 micrograms of fentanyl, you administered that order.
Yes, ma'am.
And you're certainly aware of voice reports within the hospital.
Vaguely.
Like if there was a problem, could you report a problem within the hospital, if you recall?
Yes.
And when you gave that 1,000 or administered that 1,000, we know from the records that you indicated that the patient's I can assume, would you agree with me that during your time as an ICU nurse, you had the opportunity to work with a number of different critical care physicians?
Yes, ma'am.
And even just Dr. Husel and Dr. Hagris, would you agree with me that even physicians that are similarly titled and trained do things differently?
Yes, ma'am.
And that was true of Dr. Hagris and Dr. Husel, was it not?
Absolutely.
I know you were asked about it, but two more points. The nursing station, as you recall, there was more than one on the ICU floor?
Yes, ma'am.
And during a palliative extubation and the extubations that you participated in, were there times when you would leave the room to allow the family to have time with their loved one?
Yes.
And when you did that, where generally, in your experience, would you go?
We would go to either the nursing station, or we would go look, if we had to go look at our other patients, we would go and we would proceed for assessing our other patient.
And fair to say, if you're at the nursing station, there are monitors there which allow you to continue to see what's going on in the room.
Yes, ma'am.
And while the machines visually and auditorily are shut off in the room, the patient's still being monitored even after they're extubated, right?
Yes, ma'am.
And that's information that you would continue to have access to as a nurse.
Yes, ma'am.
You were asked about the code changes. I think you were asked about the DNR and CC.
Yes.
And DNR CC. Do you remember that?
Yes.
And DNR CC, the CC stands for comfort care,
Yes.
correct?
Yes.
And in your experience, you talked about 50-ish palliative extubations.
Yeah.
At that point, when the family or next of kin makes the decision to palliatively extubate their family member or loved one, the focus is on comfort, is it not?
Absolutely.
I just want to go lastly to Dr. Husel. Just in your experience with him over the years when you were at Mount Carmel, he was nice?
Absolutely.
Seemed very smart to you?
Yes.
Approachable?
Oh, yes.
Accessible?
Yes.
Kind of person, if you had an issue, you could go to him?
Absolutely.
And he was receptive to change?
Yes.
And you told the police that, didn't you?
Yes.
And he was even someone that you had a professional relationship with?
Yes.
Yes. And you had a good relationship overall, did you not?
Yes.
Nothing further, Your Honor. Thank you.
Thank you, Your Honor. Mr. Springer, let's go back to Mr. Allen, or Mr. Hayes, okay? And again, this is State's Exhibit 2F, Ryan Hayes. All right, and on cross, you were asked about the pain score of 0 on April 2nd, 2017. Do you remember that?
Yes.
And that was 24 hours before he...
Yes.
Let's talk about the pain scores down here. What date were those on?
4/3/2017.
What time?
22:57 and 23:16 or 23:16.
Well, nope, let's go above.
Sorry.
That's okay. That's when you did the 10, correct? The
yeah.
2316?
It's at 17:40. Oh, jeez. Sorry, I'm like...
No, that's okay. 1749. It's
19,
okay.
21, 21, 21, 22, 59, 118, and 5:36.
All right. So April 3rd, 2110 is about 2 hours before. Would you agree?
Correct.
And you had a 0.
Yes. Sorry.
And that pain score of 10 was when the palliative extubation was occurring?
Not mine, looks like when Troy did, I'm assuming that's when it was going on, but mine had already passed. The excavation had already been performed.
Right, and on direct, you indicated that 10 was anticipatory when you entered it.
Yes, ma'am.
Ms. Belisari, State's Exhibit 1E. Ms. Belisari?
Yes, ma'am.
And going back to the note that was on cross-examination, she's intubated at this time
Yes, ma'am.
on a ventilator.
Yes, ma'am.
And that, you indicated that her pain was relieved with that medication.
Yes.
Now, Miss, you were asked on cross-examination regarding the biting down on the endotracheal tube.
Yes.
If you had observed any pain in her, would you have gone to the doctor for more pain medication?
I would say yes.
When you say anticipatory pain, what do you mean by that, Mr. Springer?
Just because, a person, say, doesn't, how can I phrase it? Just because they may not show signs, you would assume, or you wouldn't, if they can't say anything to you, you can still anticipate that they're still going to have pain based off of what has happened to them, color changes, things like that.
So this is something you're foreseeing could happen?
Yes.
Okay. Thank you. No further questions, Your Honor.
Your Honor,
Actually,
thank you.
on the anticipatory.
I do, thank you.
Could I have the exhibit, please? Oh, sorry, that's all right.
Based on that line of questioning, you would agree that anticipatory means you're anticipating something that will happen in the future?
Well, I'm anticipating at the time that something is, I guess, happening, if that answers your question.
It does. I just want to make sure, though, that we have the timeline correct. Right here, where you've entered the pain score is 10, it's 2316, is it not?
Yes.
On 4/3 of 2017.
Yes.
And then I want to go now to the MAR. Or I'll go rather to the order sheet. And fair to say that this is your name right here?
Yes, ma'am.
And the time here is 23:15.
Okay, yes.
So the order predates your entry that the pain was 10.
Yes.
Okay, so to say it was anticipatory, it actually is entered after the order for the medication, correct?
Say that again, sorry.
2315 comes before 2316?
Yes.
Okay. Nothing further, thank you.
You may step down.
Thank you.
Why don't we take an early lunch, since it doesn't make sense to start somebody in 5 minutes. Let's come back at 1:20. Okay? That give you guys enough time to nourish yourself? Okay. All right. Call them up. Remember the admonition, we'll see you at 1:20.
Oh, here, you know what?
Just so everything is the record.
No, Your Honor. Yes, hang on. Better way to do this, because I can mark my expenses.
Mr. Massey, anything for the record?
No, thank you.
Yep,
Wrong break your line.
you know what? You just give me the numbers. Yep.